like to invite Dr. Davari to speak on cone beam computed tomographic comparison of chin symphysis bone particles and allograft versus iliac crest bone graft alone for reconstruction of alveolar bone defects in cleft patients. Doctor is affiliated to Islamic Azad University, Isfahan branch, Iran. Yes, Dr. Davari, I would like to welcome you.
Hello, can you see me?
Yes, we are able to hear you. The floor is yours, Doctor.
And you can see me? Can you see my data?
Yes,
okay,
Doctor,
good.
yes.
Okay, good.
Yes, over to you, sir. Yes.
Okay. My slide. Okay. You can see these slides, okay? Okay, good. In the name of God, the merciful, I am Dr. Davari, oral and maxillofacial surgery assistant professor from Iran. Thank you for your attending of alveolar clefts. We have two methods for treat these patients: chin symphysis plus allograft versus iliac crest bone graft. For introduction, orofacial clefts are the most incident congenital abnormality of the face and neck, which involve jaws, lips, heart, and soft plate. Environmental factors like maternal hormone disorders, neurologic drugs, vitamins, and folic acid deficiency, hypoxia, and smoking of mother, even obesity of the mother can cause this abnormality, and can affect the patients and infants to when he is the adult. This is classification of Dr. Tessier. You can see in the image, Dr. Tessier was a great professor and great craniofacial surgeon. He's the father of craniofacial surgery. He treated many patients with ballistic and traumatic disorders and cleft patients specifically. Most of the alveolar clefts you can see in the image are number 1 and number 2 of tissue clefts. They have the sequence from mild to more severe, unilateral or bilateral, and only lips, for example, some disorder is from only lips and alveoli, and some in the palate and palatal shapes in unilateral and bilateral. Okay, it's the real shape of these patients, these infant patients, and from mild to more severe and bilateral, you can see lip, alveoli, maxillary shells, and nose have effects from this disorder. They need a sequence of treatments from the birth to adolescence. Lip surgery can be done in 3 to 4 months of the birth, after the birth, and some treatments like NAM or nasoalveolar molding can be done in first weeks of the infancy, because we can mold the lateral cartilage of the nose in the infancy without any surgery in first weeks. And in the later slide, I can show this device. Palatal surgery in 9 months to 1 year old, and switch evaluation around 2 years old. And alveolar bone grafting is our topic is in the 7 to 9 years old. We can do revision deep nose in this procedure in alveolar bone grafting. Orthodontic surgery can be done when the patient is after adolescence and after maturation, for example, in 17 years old. The important factor is that nose rhinoplasty, final rhinoplasty must done after the orthognathic surgery, as maxillary surgery can effects in the nose appearance, and then you must done nasal surgery after maxillary surgery. We can see here the treatments, effect of treatments, and the satisfying results in the lip and nose of the patient in this infant. And psychological effect is more important for parents. And when the child go to school, it's more important for him or her. He's Mr. Joaquin Phoenix. He is the actor in Gladiator. If you can see the scar in his lips, but the correct treatments make his self-confidence and make his appearance so well, then he can be actor. In lip surgery, as I told, maybe nasal columella can be managed in the some way, and it's land device. This part, the part of the device put in the nursery and shape the lower lateral cartilage, and the part put in the most of the patient in the near alveolar process, and affect the alveolar process much close, and the surgery will be not if the alveolar process go near to each other, maybe we don't need surgery or progressive surgery. In this slide, you can see the cleft area and intraoral area. These patients have missing teeth, and some have embedded teeth. They have oral communication, oral and nasal communication, who can that can push the food from oral to the nasal cavity, or nasal secretion to the oral cavity. Some advantage of alveolar bone graft is maxillary arch stability, oral fistula elimination, ideal bone support for teeth eruption, and provide nasal-based soft tissue support, creating better support for future implant placement. Because we have sometimes missing teeth in this area, sometimes we have embedded teeth. It's the schematic picture that shows what we are doing in alveolar bone graft. We separate the mucosa of the nasal and oral part, and then push the bone particle in the cleft area, and then suturing the nasal floor and mucosa of the oral mucosa. We have different donor sites for graft in the cleft area. One of the most popular is iliac bone graft. It's as you are seeing in this picture, is maybe it's more traumatic, and lateral femoral nerve may be damaged, and the patient may have some gait disturbance. Tibial bone is another source, but you know, in childhood, epiphyseal plate are the growth center, and if the damage to epiphyseal plate, maybe growth disturbing these patients. Alveolar graft is another source. It has mesenchymal origin, and so the remodeling process is better. And can you see me and here?
Hello.
Hello. Can
yes,
you
doctor.
See? Can you hear?
Yes.
Okay.
Yeah.
Okay.
Yes, doctor. We are able to hear you.
Okay. Okay. Thank you. Calvarior bone graft is another source, but it has some disadvantage. For example, duration of the operation. Operation duration is much more than intraoral or even iliac crest bone graft. And in bald patient, the scar may be visible. In another patient, maybe they have hair loss, and even dura hemorrhage may be occurred. Intraoral graft, symphysis graft is the ideal source from intraoral grafts, and PRF is another choice. Some says PRF is good for healing and remodeling of the bone in alveolar cleft patients, and in next slides I will discuss much more about that. You can see when it's alveolar cleft in 3D skull of the image of the patients, and after graft, tooth eruption, canine eruption has been occurred. The best time for alveolar bone graft is when a patient is about 6 to 10 to 11 years old, depending on the patient, because 2/3 or 1/2 of the roots of the embedded tooth must be made, and then it will rub more easily. We use circular incision in the area and a cleft, separate the nasal mucosa. You see the cleft here. 3-point bar in 6 diameter we have used to harvest the bone in monocortical pattern, because as we know, we have mental nerve here, and maybe if we don't be careful and aggressive, maybe we have lip paresthesia, and even and maybe root damage be occurred, and so we was moved too careful for harvesting, and we use allograft to half autograft from symphysis and half allograft, and then we fill the clefts and then suture. Okay, in this investigation we have two groups. Group A, who was treated with chin symphysis bone plus allograft, and Group B, who treated with iliac bone graft. Mean age and sex of between two groups wasn't meaningfully different, and most of the clefts are in the left side. The reason is unclear, but most of the cleft of the lip is in the left side. And what you see in the group A, it's equal. Right side and left side are equal, and in group B, most of the cleft was in left side. For evaluation of the remodeling of the bone and bone bridge after surgery, most of the articles before us use Bergland scale or Bergland classification. It's depend on plain film and plain radiograph like OPG or PA radiology graphy, and type 1 and type 2 of Bergland classification consider as successfulness. Type 1 and type 2 means more than 50% of the bone is in the place, and after remodeling are in the place. But we use for more precise and meticulous evaluation of the cleft in 3 dimension, we use CBCT. CBCT is kind of radiography like CT, but it has much less, it's cheaper, and those radiologic dose of the patient is much lower. I use this formula, sum of area of axial plan in extension coronal plan divided by the number of scanned cuts. It's schematic. The schematic image is CBCT. It's more used for pathologic feature and implant placement or fractures of the partial skeleton, like maxilla and mandible. We have in this image, we have it shows we have axial plan, coronal plan, and sagittal plan. For evaluation of the defect value, we use axial and coronal plan. Inferior border was CG of dental adjacent to the cleft, and the roof of the cleft, roof of the area was floor of the nose. You can see the area we use 3D software that calculate the area in square millimeter. CBCT or cone beam computed tomography was taken before surgery and 12 months following surgery to assess the status of the reconstructed alveolar cleft. As I told you, PRF, some others say PRF may be helpful in treatment of cleft patients. My great friend and great co-workers, Dr. Azad, has an investigation before. This investigation that I am presented for you, he used chin symphysis allograft plus PRF versus iliac bone graft, and his result was that both of the methods was successful, and no meaningful difference between two approach. But as you see, in this evaluation, we don't use PRF, and the percentage of bone filling was 76.9%. But when he used PRF, the percentage of bone filling was 69.5. Not meaningful difference, but it seems without PRF, we have even better results and comparable results with iliac bone graft. Let's see, iliac bone graft in our research was 77% bone filling, and the duration of surgical process disturbance, because we don't
we are able to hear you. Yeah.
Okay, good. Shirzadeh is done another investigation and report with chin symphysis bone graft. He has low morbidity, and most of the patients, 77.8%, have had normal bone height, meaning Bergland classification number 2 and 1, because he used the dimension and CBCT. Thank you for your attention.
Yeah. Thank you, Dr. Davari.
Thank you so much.
It was very amazing presentation. It was very nice to hear your excellent work and excellent transformation after the procedure. Thank you so much.